greater than the 0.
Sir, we are live.
Patricia, you can start.
Yes, sir. Okay, sir. Good morning, everyone. I am Dr. Pratyusha, doing DRNB residency in Medicover Hospitals. Today, my topic of presentation is disorders of potassium, hypokalemia and hyperkalemia. My moderator is Dr. Srinivas Samvedam, sir. Potassium is the most abundant intracellular cation and is maintained within narrow physiological range. Normally ranges from 3.5 to 5 milliequivalent per liter. Alterations in electrolyte concentrations occur frequently in critically ill patients, likely the result of malnutrition, end organ dysfunction, comorbid diseases, and polypharmacy. Early recognition and treatment of potassium abnormalities are essential, as both hyperkalemia and hypokalemia are associated with an increased risk of mortality in ICU patients. Approximately 2% of total body potassium is in the extracellular fluid, and 98% of potassium of the body weight is comprising of intracellular space and extracellular space. The extracellular fluid is comprising of 20% of the body weight. So extracellular fluid comprising of interstitial space, intravascular space, and red blood cells. So intracellular space having potassium as a major intracellular cation is about 151 millimole per liter. Whereas in extracellular space, potassium is about 4 millimole per liter and sodium is the major cation. Regulation of potassium balance. Regulation of potassium balance is mainly by two mechanisms. One is renal regulation, the other is intercompartmental shift between ICF and DCF. Renal regulation. Dietary potassium intake is excreted almost entirely by the kidneys, although small amounts are lost in sweat and gastrointestinal fluids. Almost all potassium in the glomerular filtrate is reabsorbed. Therefore, urinary potassium comes from secretion into the tubular fluid in the distal renal tubular cells, especially cortical collecting tubules. Potassium excretion is filtered by increased aldosterone. Renal tubular flow in distal nephron affects potassium secretion. How? Because high tubular flow rates increases potassium secretion by keeping the capillary renal tubular gradient for potassium secretion to be high. Conversely, it is true. Conversely, slow tubular flow rates decrease potassium secretion. So here is the where there is high potassium reabsorption, and in the distal convoluted tubule and collecting tubules, there is high potassium secretion. High potassium secretion is more pronounced in collecting tubules. Coming to intercompartmental shift between ICF and DCF. In exercise, there is increase of potassium by 0.3 to 2 millimole per liter. 0.3 to 2 millimole per liter of release of potassium by muscle cells will be there depending on the intensity and duration of the muscle activity. Change in pH. During acidosis, H+ ions enter cells displacing potassium to move extracellularly, thereby increasing the concentration of plasma potassium. During alkalosis, intracellular H+ ions leave the cells, moving extracellular potassium into the cells. Coming to the insulin, insulin enhances activity of membrane-bound sodium-potassium ATPase, which increases cellular uptake of potassium in the liver and skeletal muscle, thereby decreasing the plasma potassium concentration. Sympathetic activity. Sympathetic beta-2 receptor stimulation enhances the activity of sodium-potassium ATPase, which increases cellular uptake of potassium, thereby decreasing the plasma potassium concentration. Coming to the plasma osmolality, an acute increase in plasma osmolality, like in hypernatremia, hyperglycemia, or mannitol administration, causes movement of water out of cells down its osmotic gradient, leading to cellular dehydration, which increases intracellular potassium. This causes movement of potassium out of cells, which increases plasma potassium concentration. There will be an increase of 0.6 millimole per liter of potassium per 10 milliosmol per liter of plasma osmolality increase. Coming to hypothermia, it causes cellular uptake of potassium, decreasing plasma potassium concentration. Rewarming reverses the shift, leading to a transient increase in plasma potassium, resulting in hyperkalemia. So in hypothermia, we see hypokalemia. In hyperthermia, we see hyperkalemia. Coming to hypokalemia etiologies. Without any change in total body potassium, if there is any intercompartmental potassium shift causing hypokalemia, these will be the causes. Hypokalemic periodic paralysis or metabolic or respiratory alkalosis, insulin administration, use of beta agonists like bronchodilators, albuterol, or tocolytics as they stimulate sodium-potassium ATPase activity, theophylline, hypothermia, treatment of megaloblastic anemia with folate and vitamin B12. This increases red blood cell and platelet uptake of potassium. Transfusion of frozen red blood cells as they lose their potassium in the preservation process. Hypercalcemia or hypomagnesemia. The other mechanism will be decreased total body potassium. There will be depletion of potassium. This might be due to either increased renal losses or increased extrarenal losses or decreased potassium intake. So coming to increased renal losses of potassium, there will be urinary potassium greater than 20 millimole per liter. It is seen in diuretics, use of diuretics like loop diuretics or thiazide diuretics, diabetic ketoacidosis conditions, renal tubular acidosis, salt wasting nephropathy, renal artery stenosis, hypomagnesemia. It reduces sodium potassium ATPase pump activity, impairing the intracellular uptake of potassium and also impairs repletion of potassium stores. Hypomagnesemia impairs potassium reabsorption across the renal tubules. Or use of amphotericin B therapy, renal failure case, whereas in diuretic phase, urinary diversion with a long ileal loop, increased mineralocorticoid activity as seen in primary hyperaldosteronism, like in Conn syndrome, secondary hyperaldosteronism, like in edematous disorders, renovascular hypertension, and renin secreting tumor, mineralocorticoid tumors, glucocorticoid excess as Cushing syndrome or corticosteroid therapy, congenital adrenal hyperplasia. Or in surgical trauma, high doses of antibiotics as penicillin, ampicillin, or aminoglycosides, causing magnesium depletion will also be there. So hypomagnesemia causing hypokalemia. Coming to extrarenal losses of potassium, urinary potassium less than 20 millimole per liter will be there. It is seen in conditions like diarrhea or laxative abuse, vomiting or nasogastric suction, excess suction of HCl leading to alkalosis, fistula, urinary diversion with ureterosigmoidostomy, jejunal bypass or malabsorption, villus adenoma, pancreatic tumor secreting vasoactive intestinal peptide, excessive sweating, dialysis with a low potassium containing dialysate solution, chemotherapy. If there is any decreased potassium intake, the urinary potassium will be less than 20 millimole per liter. It is a very rare cause. Coming to hypokalemia clinical picture. The severity of clinical picture depends on the rapidity of the decrease in serum potassium. In asymptomatic cases, especially in chronic cases with serum potassium less than 3 millimole per liter, the patients will be usually asymptomatic. Cardiovascular effects will be like contractility is depressed, orthostatic hypotension will be there. There can be arrhythmias, myocardial fibrosis with chronic hypokalemia. ECG changes will be like due to delayed ventricular repolarization in hypokalemia. There will be T wave flattening or inversion, apparent U wave, ST segment depression, increased P wave amplitude, prolonged PR interval. Skeletal muscle effects. We can see the weakness, especially quadriceps and cramping. It may progress to respiratory muscle weakness and respiratory failure. Tetany, ileus, rhabdomyolysis will also be seen. Renal effects. Nephrogenic diabetes insipidus causing polyuria, where in condition we see resistance to antidiuretic hormone. Increased ammonia production, increased bicarbonate reabsorption leading to metabolic alkalosis, increased sodium retention, tubulointerstitial nephropathy. We see fibrosis with chronic hypokalemia. Endocrine effects are like decreased insulin secretion leading to hyperglycemia, decreased growth hormone secretion, decreased aldosterone secretion. Metabolic effects are like negative nitrogen balance. Encephalopathy in patients with liver diseases, especially with metabolic alkalosis and increased ammonia production. Coming to hypokalemia, assessing the severity. If the serum potassium level less than 3.5 millimole per liter, we see whether it is an emergency or not. If it is an emergency, we move to the therapy. If it is a pseudo hypokalemia, we don't do any workup. If the hypokalemia is not an emergency and is true, we see for history, physical examination, and basic laboratory tests. Check for any evidence of low potassium intake and treat accordingly. Check for any evidence of transcellular shift and treat accordingly, like in conditions insulin excess or beta-2 adrenergic agonist, familial hypokalemic periodic paralysis, hyperthyroidism, barium intoxication, or theophylline, chloroquine use. If there is no evidence of low potassium intake or transcellular shift, go for urine potassium. If it is less than 15 millimole per day, see for extrarenal loss. See for acid-base status in such conditions. If it is normal, that might be due to profuse sweating. If there is metabolic acidosis, that might be due to GI potassium loss. If it is a metabolic alkalosis condition, it might be due to remote diuretic use or vomiting or stomach drainage or profuse sweating. If the urine potassium is greater than 15 millimole per liter per day, it indicates there is renal loss. So we see for transtubular potassium gradient. Transtubular potassium gradient, if it is less than 2, it says that there is increased tubular flow rates, as in conditions osmotic diuresis. If TTKG, transtubular potassium gradient, greater than 4, it says there is increased distal potassium secretion. So then we see for BP and volume status. So in BP and volume status, if it is low or normal, we again see for acid-base status. If the acid-base status is variable, we check for the non-reabsorbable anions other than bicarbonates like hippurates, penicillins, or usage of penicillins. Or acid-base status, if it is metabolic acidosis, this might be due to proximal renal tubular acidosis, distal renal tubular acidosis, DKA, amphotericin B, and acetazolamide use. If there is metabolic alkalosis, check for urine chlorides. If the urine chlorides are less than 10, it might be due to vomiting or chloride diarrhea. If the urine chloride values are greater than 20 millimole per liter, check for urine calcium to creatine molar ratio. Urine calcium to creatine molar ratio, if it is greater than 0.2, this is mostly due to loop diuretics or Bartter syndrome. If the urine calcium to creatine ratio less than 0.15, this might be due to thiazide diuretic and Gitelman syndrome. Otherwise, if the BP and volume status is high, see for aldosterone levels. If the aldosterone levels are high, check for renin. If the renin is high, it might be due to renal artery stenosis, renin secreting tumors, malignant hypertension. If the renin values are low, it might be due to primary aldosteronism or familial hyperaldosteronism. If the aldosterone levels are low, see for cortisol. If the cortisol is high, it might be due to Cushing syndrome. If the cortisol is normal, it might be due to Liddle syndrome, licorice, or syndrome of inappropriate mineralocorticoid excess. Coming to hypokalemia treatment. Urgent intravenous correction is needed in the following conditions. If there is any ECG changes in hypokalemia, if there are any cardiac arrhythmias, severely impaired neuromuscular function, diaphragmatic weakness, and respiratory failure. Patients on digoxin or antiarrhythmic therapy. If the patients are in old age, organic heart disease, serum potassium of less than 3 milliequivalent per liter, DKA, hyperosmolar non-ketotic diabetes. In these conditions, urgent intravenous correction of potassium is required. Estimate the potassium deficit. Approximately 200 milliequivalents of potassium deficit is required to decrease serum potassium value by 1 milliequivalent per liter in chronic hypokalemic patients. In acute situations, serum potassium concentration falls by approximately 0.27 milliequivalent per liter for every 100 milliequivalent reduction in total body potassium stores. These are only an approximation, and careful monitoring of serum potassium is required here. This approximation only takes into consideration of potassium deficit, but does not account for ongoing losses or intracellular shifts and daily maintenance requirement of potassium. Daily requirement of potassium is around 40 to 120 milliequivalent per day. Detailed history and physical examination should be performed to look for systemic causes of hypokalemia. History of increased urinary or gastrointestinal loss of fluid seen like in vomiting, diarrhea, polyuria. This history should be taken. Detailed drug history to rule out drug-induced hypokalemia should also be taken. Urinary potassium level of more than 30 milliequivalent per day is a feature of loss of potassium in the urine. This can be calculated by the following: either by 24-hour urine collection and measuring potassium concentration, or by spot urinary potassium. If spot urinary potassium is less than 15 milliequivalent per liter, it suggests that there is no urinary cause of hypokalemia. Spot urinary potassium to creatine ratio, if it is more than 13 milliequivalent per gram of creatine, it indicates there is inappropriate urinary loss of potassium. Assess the acid-base status. If there is metabolic acidosis with low urinary excretion of potassium, this might be due to lower GI loss like in diarrhea. If there is metabolic acidosis with high urinary potassium excretion, this might be due to DKA or type 1 renal tubular acidosis. If there is metabolic alkalosis with low urinary excretion of potassium, this might be due to upper GI loss like vomiting or previous diuretic use. Metabolic alkalosis with high potassium urinary loss, it might be due to recent diuretic use or primary hyperaldosteronism. Replacement of potassium chloride by intravenous route, either by peripheral route or by central route. Peripheral route, it is safe when 1 ampule of potassium chloride contains 20 milliequivalents of potassium. It is used in mild to moderate hypokalemia, like in 3 to 3.5 milliequivalent per liter. 20 to 40 milliequivalent per liter of potassium chloride is added to 1 liter of fluid and given over 4 to 6 hours. A saline rather than dextrose solution should be used. Half-strength saline with 20 milliequivalent of potassium chloride makes the solution isotonic and suitable for peripheral use. Do not use high concentrations of over 60 milliequivalent per liter because it can lead to pain and sclerosis of the peripheral vein. Volume overload is a potential risk in susceptible subjects. Central route. It is used in severe hypokalemia, like in 2.5 to 3 milliequivalent per liter of potassium. Prepare 20 milliequivalent of potassium chloride in 100 ml of normal or half-strength saline. 5 to 20 milliequivalent per hour can be safely administered by given through central route. Potassium chloride is of choice with metabolic alkalosis as it corrects chloride shifts. It is the most common type used. Potassium bicarbonate, potassium acetate, or potassium citrate is of choice with metabolic acidosis. Potassium phosphate is of choice with coexisting hypophosphatemia, that is in diabetic ketoacidosis. Life-threatening arrhythmias. Precautions to avoid life-threatening arrhythmias while correcting the hypokalemia. Up to 40 milliequivalents of potassium chloride per hour can be given over a few hours. For a few hours. No other infusion should be going through the same catheter. Avoid blood sampling and flushing through the catheter. Frequently monitor potassium levels till 3 to 3.5 milliequivalent per liter. Continuous ECG monitoring is required. Frequent potassium monitoring is needed during treatment as there is no available equation which can accurately calculate the amount of potassium given. Avoid dextrose-containing solution as the resulting hyperglycemia and secondary insulin secretion decrease serum potassium further. Correction of hypomagnesemia is needed in refractory hypokalemia. Magnesium deficiency, hypomagnesemia and hypokalemia. Magnesium depletion has inhibitory effects on muscle sodium potassium ATPase activity, reducing the influx into the muscle cells and causing secondary kaliuresis. Kaliuresis is the urinary excretion of potassium. In addition, magnesium depletion causes exaggerated potassium secretion by the distal nephron. This effect is attributed to a reduction in the magnesium-dependent intracellular block of potassium efflux through the secretory potassium channel of principal cells, ROMK channels. In consequence, hypomagnesiemic patients are clinically refractory to potassium replacement in the absence of magnesium repletion. Replacement of potassium orally. Once seropotassium has been raised to a safe limit of about 3 milliequivalent per liter, the rest of the replacement may be done slowly by oral route. This could be achieved by adding potassium-rich diet, potassium salt, potassium chloride suspension. Treatment is usually started with 10 to 20 milliequivalents of potassium chloride given over 2 to 4 times per day, that is 20 to 80 milliequivalents per day. Reduce the loss of potassium. In patients with hypokalemia, due to increased urinary losses, potassium-sparing diuretics such as spironolactone, amiloride, or eplerenone may be tried. Oral or IV potassium should be used with caution in these situations, especially in patients with impaired renal function and on concomitant use of ACE inhibitors or ARBs. Coming to hyperkalemia. Hyperkalemia is defined as plasma potassium level of 5.5 millimole per liter occurring in 10% of hospitalized patients. Severe hyperkalemia greater than 6 millimole per liter occurs in 1% with increased risk of mortality. Although redistribution and reduced tissue uptake can acutely cause hyperkalemia, a decrease in renal potassium excretion is the most frequent underlying cause. Excessive intake of potassium is a rare cause given the adaptive capacity to increase renal secretion. However, dietary intake can have a major effect in susceptible patients, like in diabetics with hyporeninemic hypoaldosteronism and chronic kidney disease patients. Drugs that impact on the renin-angiotensin-aldosterone axis are also a major cause of hyperkalemia. Hyperkalemia etiology. Without a change in total body potassium, if there is any intercompartmental potassium shift causing hyperkalemia, there might be urine potassium greater than 30 millimole per liter in hyperkalemia. The causes are like severe exercise, rhabdomyolysis, hyperkalemic periodic paralysis, tissue breakdown after chemotherapy, burns, trauma, massive intravascular hemolysis. Use of succinylcholine, it increases serum potassium of about 0.5 millimole per liter, which is exaggerated with large burns, severe muscle trauma, and spinal cord injury. Metabolic and respiratory acidosis. Or use of arginine hydrochloride. It is used in the treatment of metabolic alkalosis as the cationic arginine ions enter the cells and potassium ions move out to maintain electric neutrality. Use of beta-2 agonists, use of beta-2 antagonists, digitalis toxicity, and hypertonicity. If there is increased total body potassium, like in case of decreased renal losses or increased potassium intake, or it might be due to pseudo hyperkalemia. Coming to decreased renal losses, urinary potassium less than 30 millimole per liter, seen in conditions like renal failure, acute or chronic, isolated decreased potassium secretion in distal nephrons as non-competitive potassium-sparing diuretics like amiloride or triamterene, sickle cell disease, renal allograft, systemic lupus erythematosus, and urinary obstruction. Decreased mineralocorticoid activity as seen in primary adrenal insufficiency like in Addison's disease, congenital adrenal atrophy or hypoplasia, ACE inhibitors or ARBs, competitive potassium-sparing diuretics like spironolactone, heparin, NSAIDs, and cyclosporin use, or in AIDS condition, acquired immunodeficiency syndrome. Increased potassium intake. Transfusion of old whole blood, serum potassium can be increased up to 30 milliequivalent per liter in 1 unit of transfused blood after 21 days of storage. Or use of any salt substitutes, potassium containing penicillins, and potassium intake especially is increased if IV correction is given rapidly or in patients who are on beta-2 antagonists with or patients with renal impairment or patients with insulin deficiency. Pseudo-hyperkalemia. Pseudo-hyperkalemia is also called as factitious hyperkalemia. It is due to false laboratory results. In vitro red blood cell hemolysis commonly occurring due to prolonged use of tourniquet while obtaining a venous sample. It is reported as a common event in about 20% of the samples. In vitro marked leukocytosis of greater than 70,000 per microliter or marked thrombocytosis greater than 10 lakh per microliter leads to release of potassium from the white blood cells or platelets respectively into the blood samples during clot formation. In such cases, potassium is better measured in the plasma sample, that is unclotted blood sample rather than serum, to reflect the true potassium value in the body. Coming to the hyperkalemia clinical picture. The severity of clinical picture depends on the rapidity of increase in serum potassium. Asymptomatic cases will be seen in chronic cases. Cardiovascular effects will be like contractility will be well preserved. Cardiac effects of hyperkalemia are exaggerated by hyponatremia, hypocalcemia, and acidosis. ECG changes due to delayed ventricular depolarizations will be there in hyperkalemia. At potassium levels greater than 7 millimole per liter, there will be symmetric tall peak T waves, shortened QT interval. At potassium levels greater than 8, so 8 to 10 millimole per liter, there will be widening of QRS complexes, prolonged PR interval, loss of P and R wave, ST segment depression or elevation, sine wave pattern, where wide QRS complex merges into T wave. At potassium levels greater than 10 millimole per liter, there will be ventricular fibrillation and asystole. Skeletal muscle effects. Weakness and malaise progress into flaccid paralysis when serum potassium greater than 8 millimole per liter due to sustained spontaneous depolarization and inactivation of sodium channels of muscle membrane, similar to usage of succinyl choline, eventually leading to ascending paralysis. Gastrointestinal effects are like nausea, vomiting, and diarrhea. Coming to the assessment of hyperkalemia. Detailed history and physical examination should be performed to look for features of diseases associated with hyperkalemia, such as renal failure and adrenal disease. History of renal disease or previous potassium levels should be looked for to assess sudden deterioration of renal function. Drug history should be taken to exclude drugs such as ACE inhibitors or ARBs, NSAIDs, aldosterone antagonists, and potassium-containing drugs that can cause hyperkalemia, especially in renal impaired patients. Check for creatine phosphokinase levels, check for lactate dehydrogenase levels, measurement of urinary potassium excretion, and transtubular estimation of potassium gradient is of limited use in deciding the cause of hyperkalemia. Serum potassium should be monitored frequently. Serum and urine osmolality are required for calculation of the transtubular potassium gradient, TTKG. The expected values of TTKG are largely based on historical data and are less than 3 in the presence of hypokalemia and greater than 7 to 8 in the presence of hyperkalemia. So transtubular potassium gradient is product of urine potassium and serum osmolality by product of serum potassium into urine osmolality. Coming to assessing the hyperkalemia, serum potassium levels greater than 5.5 millimole per liter we should check for any ECG changes are there or not. If there are any ECG changes, it is an emergency indication for therapy. If it is a pseudo hyperkalemia, no further action is taken. If there are no ECG changes, but it is a true hyperkalemia, we see for history, physical examination, and basic laboratory tests. If there is any evidence of increased potassium load, treat it accordingly. If there is any evidence of transcellular shift, treat the causes accordingly. The causes might be like hypertonicity, like in mannitol usage, hyperglycemia, succinylcholine usage, use of aminocaproic acid, digoxin, beta blockers, metabolic acidosis conditions, arginine or lysine infusion, hyperkalemic periodic paralysis, or decreased insulin, or in exercise. If there is no evidence of increased potassium load or transcellular shift, see for decreased urinary potassium excretion. If it is less than 40 millimole per day, check for urine electrolytes. If the urine sodium less than 25 millimole per liter, the condition might be due to decreased distal sodium delivery. Check for transtubular potassium gradient. The transtubular potassium gradient, if it is greater than 8, that says there is reduced tubular flows, like in conditions advanced kidney failure where GFR less than 20 milliliter per minute, or reduced effective circulatory volume. If the TTKG, transtubular potassium gradient, is less than 5, there will be reduced distal potassium secretion, as in GFR greater than 20 milliliter per minute. Then see for 9-alpha fludrocortisone, the TTKG use of 9-alpha fludrocortisone, C for TTKG, if it is less than 8, that might be due to tubular resistance. Causes are like use of drugs, amiloride, spironolactone, triamterene, trimethoprim, pentamidine, eplerenone, drosperinone, and calcineurin inhibitors. Other causes might usually be like tubulointerstitial diseases, urinary tract obstruction, pseudo-hypoaldosteronism type 1, type 2, sickle cell disease, renal transplant, or systemic lupus erythematosus conditions. If TTKG greater than or equal to 8, that might be due to low aldosterone levels. Check for renin. If the renin is high, it might be due to primary adrenal insufficiency, isolated aldosterone deficiency, use of heparin or low molecular weight heparin, ACE inhibitors or ARBs, or ketoconazole. If renin is low, it says diabetes mellitus, acute glomerulonephritis, tubulointerstitial diseases, or pseudo-hypoaldosteronism type 2, NSAIDs, beta blockers. Coming to hyperkalemia treatment. Hyperkalemia should be urgently managed in the following circumstances. If there are any ECG changes, the progression and severity of ECG changes do not always correlate well with serum potassium. Muscle weakness or paralysis, rhabdomyolysis, if there are any crush injuries, tumor lysis syndrome, or the serum potassium of more than 7 milliequivalent per liter, or rapidly rising potassium above 5 milliequivalent per liter. Treatment of hyperkalemia is by either giving calcium in the form of calcium chloride or calcium gluconate. Calcium stabilizes the myocardial membrane. It doesn't directly reduce the serum potassium levels. It stabilizes the myocardial membrane, thereby protecting from arrhythmias that are caused due to hyperkalemia. So 10 ml of 10% calcium chloride IV or 10 to 30 ml of 10% calcium gluconate IV can be given. The onset of action will be in 1 to 3 minutes and it acts for a duration of 30 to 60 minutes. The dose can be repeated after 5 minutes if the ECG changes are persisting. Use of sodium bicarbonate shifts the potassium into cells. There will be cellular uptake of potassium. So 50 to 100 milliequivalents IV or 150 milliequivalents IV over 3 to 4 hour infusion is given. Sodium bicarbonate is only effective with non-anionic gap metabolic acidosis. There is risk of fluid overload conditions. Use of insulin. Insulin also increases cellular uptake of potassium. So 10 units of IV regular insulin is given. The onset of action is in 15 minutes and works for a duration of 4 to 6 hours. Co-administer this insulin with 25 grams of dextrose to prevent hypoglycemia. Albuterol, that is salbutamol, also causes cellular uptake of potassium. Giving 10 mg of salbutamol nebulized over 10 minutes. The onset of action is in 30 minutes and works for a duration of 2 to 4 hours. There will be risk of tachycardia. Use of loop diuretics, it increases the renal potassium excretion. 40 mg IV furosemide or equivalent dose is given, and it should be administered to patients with symptomatic fluid overload conditions. Sodium polystyrene sulfonate, it increases it increases stool potassium excretion. 15 grams given orally daily for 4 times or 30 grams given rectally daily for 2 times. Its onset of action is in 1 to 2 hours and works for a duration greater than 4 hours. Sodium polystyrene sulfonate should be avoided in ileus or bowel obstruction because there are chances of intestinal necrosis. Dialysis is the ultimate way to remove potassium, high excess potassium. Hemodialysis preferred over peritoneal in acute settings. Conventional hemodialysis causes most rapid fall in serum potassium. So IV calcium can be repeated after 5 minutes if the ECG abnormalities are persisting. Concentrated calcium solution is tissue irritant and should be given in a large peripheral vein or central vein. Calcium should not be given in bicarbonate containing solutions to avoid precipitation of calcium carbonate. Calcium should be given cautiously as a slow infusion in patients on digitalis. Insulin with glucose. Monitor blood glucose for every 30 minutes. And insulin and glucose lower serum potassium by driving potassium inside the cells. It decreases serum potassium value by 0.5 to 1.2 milliequivalent per liter. And we should be aware of hypoglycemia in renal failure patients. Salbutamol nebulizers. Its effect is seen in 90 minutes of nebulization. 60 to 90 minutes of nebulization, serum potassium will decrease by 0.5 to 1.2 milliequivalent per liter. It works by driving potassium inside the cell. Sodium bicarbonate, it should be given cautiously in selected cases of hyperkalemia associated with severe metabolic acidosis. Usual dose is 25 milliequivalents or 50 milliequivalents to 100 milliequivalents in some severe cases, infused over 5 minutes. Intravenous loop diuretics. In patients with normal or mildly impaired renal function, intravenous loop diuretics can be tried for hyperkalemia. Diuretics, a trial of diuretics in patients with preserved renal function and volume overload state may be done. Cation exchange resin. Sodium polystyrene sulfonate is a cation exchange resin. In the gut, sodium polystyrene sulfonate takes up potassium and calcium, magnesium to a lesser degrees and release sodium. 1 gram binds to 1 milliequivalent of potassium. It is usually given orally 3 times daily, but may be given rectally also. Oral dose is usually 20 grams given with 100 ml of 20% sorbitol solution to prevent constipation. A major concern with sodium polystyrene sulfate in sorbitol is the development of intestinal necrosis, usually involving the colon and the ileum. The serum potassium falls by at least 0.4 milliequivalent per liter in the first 24 hours. Patiromer is recently approved gastrointestinal potassium exchanger. Dialysis. It is indicated if hyperkalemia persists in spite of above measures or patients having any other indication of dialysis. Hemodialysis can remove 25 to 50 milliequivalents of potassium per hour with variability based on the initial serum potassium concentration, the type and surface area of the dialyzer used, the blood flow rate, the dialysate flow rate, the duration of dialysis, and the potassium concentration of the dialysate. We should be aware of rebound hyperkalemia after dialysis. Precautions to be taken while correcting hyperkalemia. ECG should be monitored continuously. Avoid giving succinylcholine, potassium-containing solutions like ringer lactate solutions, or avoid metabolic and respiratory acidosis to prevent further hyperkalemia. Key points. Hyperkalemia and hypokalemia have been associated with increased mortality in critically ill patients. Although classic ECG abnormalities are commonly described, severe hyperkalemia may present with minimal or atypical ECG findings also. A synergistic hypokalemic response occurs when salbutamol and insulin are co-administered. Severe hypokalemia can produce ventricular arrhythmias or cardiac arrest. IV potassium repletion should be reserved for patients with severe hypokalemia, those with ECG changes, or those unable to tolerate oral administration. Thank you all.
Thank you, Pratisha, for a very crisp but comprehensive review of the management of the potassium imbalance. This is something which happens very frequently in intensive care practice, which is more often a acute phenomena which brings patient into the intensive care unit. And some of the interventions which we do in intensive care can shift the potassium balance either way between hyper and hypokalemia. A common situation where we make errors in the management of potassium is when patients come with hyperglycemia. We interpret it as DKA and we try to start insulin without understanding the dynamics of the potassium balance and the relationship with insulin, which can trigger arrhythmias in these patients. The second problem which happens is with the use of sodium bicarbonate. Now, we are actually learning the habit of giving bicarb for every acidosis, and we should remember that sodium bicarbonate drives potassium into the cells, so it can trigger a hypokalemic crisis. And recently, it has also been described that the calcium gluconate, which we use in hyperkalemia, does not just produce membrane stabilization, but it actually causes a shift of potassium back into the intracellular compartment. Some of the drugs which we use in routine practice, like pantoprazole, for example, can produce hyperkalemia in patients who have another condition which is known to trigger a hyperkalemic situation. So, this awareness of the drugs also is very important. Ghanshyam?
Thank you, Srinivas. Thank you, Pratisha. Just a couple of points. See, whenever we are looking at electrolyte abnormalities, majority of the electrolyte abnormalities, especially like, for example, potassium, in isolation, probably they are well tolerated. But when you have other conditions which can potentiate the toxicity and the harmful effects, be very, very careful. For example, you have a patient with, say, underlying coronary heart disease with conduction abnormalities. Then either potassium on the lower side or higher side is bad. Similarly, we always look for, are there any other conditions which can kind of complicate the toxicity of the electrolyte abnormalities. See, many a times we look at potassium, or we expect metabolic acidosis to cause hyperkalemia. There are just a couple of variations, like your renal tubular acidosis 1 and 2 and your diabetic ketoacidosis, where you may still have acidosis, but the potassium may be on the lower side. In intensive care, always look at interpreting potassium on the context of refeeding syndrome, especially in patients who have not been fed. You start feed, there could be a rapid fall in potassium levels precipitating a refeeding syndrome. So anticipate such disorders because these can be potentially life-threatening, and many times we may not be expecting them. Thank you.
Thank you, sir.
Thank you all. Thank you for joining us. Again, we will have a interesting session next week on a relevant topic in critical care. Please do join us next week. Those of you who have any queries on this session, please do post them on the group from where you got this link from, and we will answer them at the earliest possible time. And also, please join us for the Journal Club later this month. Thank you all and have a good day. Be safe during the immersion.
Thank you,
Thank you.
sir. Thank you, sir.